Good morning, everybody. Welcome to Phoenix Children's Grand Rounds. It's my pleasure to introduce our speakers this morning. We have two presenters today, Dr. Sam Castleman and Dr. Amanda Mahalik, who will be speaking on the topic of optimizing patient communication. Dr. Sam Castleman is a pediatric nurse practitioner in the Division of Pediatric Dermatology here at Phoenix Children's. She received her Doctor of Nursing Practice from Arizona State University. Sam also serves as an IT clinical analyst at Phoenix Children's. She is the past president of the Arizona chapter of the National Association of Pediatric Nurse Practitioners, and she is also the founder and chair of the Dermatology Special Interest Group for that same organization. Dr. Mahalik is a palliative medicine specialist at Phoenix Children's. She completed medical school at Loyola University in Chicago and a combined internal medicine and pediatric residency at Phoenix Children's and BUMCP. She is currently spearheading an initiative to improve end-of-life comfort care at Phoenix Children's. We'll welcome our first presenter, Dr. Castleman.
Good morning, everybody. Thank you, Micah, and for the CMA team for inviting us today to talk. I won't do any introductions of myself, but you'll have the pleasure of hearing from Dr. Amanda Mahalik from our palliative care team a little bit midway through the presentation. Today we'll be discussing a topic near and dear to our hearts from different perspectives. Our presentation is entitled Optimizing Communication During a Pandemic, a Difficult and Challenging Task. Neither of us have a conflict of interest related to this presentation. And we will have a few polling questions during our presentation. You should be able to participate on the Blue Zoom platform. Get that going here. Wherever you are, please sit back and take a trip down memory lane into your personal and professional experiences you've had with your patients. And please answer this polling question. Do you feel confident in your understanding and ability to provide family-centered care in your practice setting? We'll give you about 10 more seconds. And here are the results. Most of you feel that you are confident, and some of you also feel that you could use a little bit more information. So we will begin with the case study. This patient started developing dyspnea, fever, and lethargy July of 2020 and spent 2 days at home until being taken to the emergency room in Dewey, Arizona due to increased difficulty with breathing. This patient is a 65-year-old male with COPD, type 2 diabetes, a pacemaker, hypertension, overweight, and multiple spinal fixation surgeries. During the early course for this patient, from day 1 to 5, this patient developed worsening dyspnea and oxygen supplementation requirements advancing from nasal cannula to high flow BiPAP. The patient was diagnosed with COVID-19. On day 5 was a turning point for this patient. He went into cardiac arrest and was coded for 22 minutes. The family had decided that he's not a DNR, and the patient was intubated. Then from about day 5 to 65, the patient endured multiple complications. He required high pressure ventilation support. He was diagnosed with the HSV infection that was found in and around his mouth. MRSA was cultured from his ET tube. The patient developed a pneumomediastinum that was hypothesized due to the high ventilator pressure as well as proning position. Early on in the patient's course, they developed kidney failure and required CRRT throughout the duration of their hospitalization. And the patient developed sepsis also very early on. The patient continued to decline and continued to be septic with multi-system organ failure that we see so commonly in these patients with severe COVID. And despite broad-spectrum antibiotics and multiple life-saving interventions, the patient's family was called to room of care. 4 family members were able to visit the patient for the first time in their 65-day patient stay for 3 hours with the patient before removing life support, and the patient did pass quickly. It's important to note that this patient was COVID positive the entire time of their hospitalization until the day that the family was called to remove care. And at that point, when that COVID test came back negative, the patient's family went from, rather than 2 people being able to visit, now they could have 4 people visit. They also were moved from a 15-minute visit before they started to move life support to a 3-hour visit. Thus far, we've discussed the patient's medical status and outcome. But thinking about patients you've managed chronically, how would you advocate for this patient and their family? Do you communicate differently with your patients and families who are terminally ill or staying in the hospital for a prolonged amount of time? Let's see how communication went during his 65-day stay. The staff relied on patients to communicate updates in the early days of their hospitalization. Remember that he had COVID, so probably very difficult to speak. There was no discussion about advanced directives despite the patient displaying a severe COVID clinical course. So no granular discussion about whether the patient would want to live on dialysis possibly, if the patient may want to live with a trach, how long is too long in rehab. Those questions weren't discussed with the patient. And remember, the family wasn't there and also couldn't talk to him very often because of his inability to talk, because he couldn't breathe. Out of 65 days in the hospital, an attending talked with the family a total of 12 times. Residents or nurses were a primary source for communication. Hospital staff never offered video conferencing or family-centered rounding. Family wasn't able to video call with the patient regularly due to only 2 iPads for a 60-plus bed ICU unit. The family video called less than 7 times to see the patient during their 65-day stay. Palliative consultation was offered after the patient coded and denied by the patient's wife due to feelings of being forced to remove care with this type of team. This team was eventually added to this patient's care team about 2 weeks prior to them passing away. Phone calls to nursing and the floor could often also go unanswered without any way to leave a message. So as you can imagine, with no family at bedside, no video conferencing, a misconception of palliative care, and inconsistent communication, it would be really difficult for this family to look over this wall and find trust. Trusting relationships with the providers were not very sound or lengthy because of the rotation of the residents along with the intensivists changing weekly. This poses a question. Did the communication challenges COVID-19 presented create insurmountable obstacles that couldn't be overcome? The evidence points to no. National organizations such as the Institute for Patient and Family-Centered Care provided guidelines and experiences to aid with restrictions and communication challenges during the pandemic in April of 2020. Highlighted in the middle, you'll see that virtual communication was of emphasis, possibly hospitals thinking about providing or loaning tablets to their patients, and allowing staff to be somewhat of a champion and that resource so that families can understand how to utilize Zoom and the different video technologies that can be challenging for even myself being in IT. There was also an emphasis to find opportunities to connect with families virtually as they were viewed as an important member of the care team. This is a different guideline created by the National Collaborating Center for Mental Health. This guideline is unique in that it outlines various scenarios outlining problems presented during the pandemic and real-life experiences in developing programs to improve mental health for patients and employees. Without going into great detail, here's an example of real-life scenario seeking to improve family connectedness during visitor restrictions. So the problem that they were faced with is that patients were becoming tearful and asking when their families would come to visit. They utilized Samsung tablets that were already on the ward and set up video conferencing. And the feedback is generally that it went well to those with the capacity and those who were asking to see family. Overall, there were many benefits for the patients who could have visual contact with their family as well as from the employees. I thought that this was a really nice infographic also found in this guideline, developed to combat the challenges of having difficult conversations with families. A simple Google search of improving family connectedness during the pandemic will bring you to several publicly available guidelines that were created as early as 2020. and to meet the need of the unique challenges the pandemic presented to us. So remembering our patient, recall the previous slide with communication issues. Their medical stay was important and also emphasized and articulated to the family. However, the stay was also wrought with many communication breakdowns and disappointments, therefore inhibiting trust between the family and with the care providers. One could chalk this up to bad timing. Remember that hospitalization was from July to September of 2020. And no offense to any residents that are listening in today on Grand Rounds, but we all love to welcome you in July, but also experiences some challenges as you can remember, students and residents weren't able to necessarily even participate in patients' care during that time. Therefore, they were utilized for the communication because then PPE and that one-on-one presence with the patient just wasn't allowed at that time. Also, was it too early to have expected the hospital to have a communication plan in place? There's really no perfect answer. But there are potentially a significant number of individuals with the same story as our patient. This was taken a screenshot just yesterday of our COVID rates of death, both in the US and worldwide. So I might have stumped some of you because I know that obviously I do not look like the patient if you remembered his photo from the first. And some of you may know my patient's story, but unfortunately, this patient in this case study was my dad. I really thought that we had our odds in our favor, with myself being a nurse now since 2009 here at this facility, became a nurse practitioner in 2015, and my IT days are just 3 years now, which seems like forever. But my aunt was also a participant in the daily calls, and she was actually the risk manager for this hospital that my dad was staying at, and she had worked there for about 20 years. So every day, myself, my aunt, and my stepmother were on calls with the team, and so we really felt that we had a good, solid team that would be able to advocate for him. But looking back, it really feels that we were advocating very little for our family as well as for what my dad would want. And we too got caught up in focusing on the medical. Every day they would call and let us know what his heart was doing, what his lungs were doing, what his kidneys were doing. And sometimes that by the time that we were done discussing that over 10 to 15 minutes, you could sense that there was a rush to not need or be able to talk about any more information, frankly, because mostly these were residents that we were talking to. Occasionally it was nurses, but primarily residents. And they oftentimes gave us the blanket discussion of, well, we don't know about the pandemic and we don't know the outcomes. It's a very unprecedented time. And once you hear that every day for a given period of time, not being able to talk to an attending to be able to impart what they're thinking about for a clinical plan for my dad was very, very frustrating. And what really settles very difficultly with me is the fact that my dad was not the same man that I knew before he went into the hospital. So the man on your right is a picture of my dad that I've only known him to be that size through photos. This was taken many, many moons ago when he was a military police officer. And this is akin to what the size of my dad looked like. To preserve his dignity, I did not take any photos when I saw him, but what really was very difficult for us to see is that when we were discussing these reports with the staff, they did not let us know his weight. Maybe I should have thought to ask. Again, I work in dermatology. I don't go into the hospital and see patients who are in the ICU. But over the 65 days, he did require a paralytic for a majority of the time. And after a point of removing the paralytic, there was this constant discussion of, well, he's not moving his arms and his legs. It's been a week or two, but there was never this advocacy on his part to say, hey, like, I know that you guys are thinking that this man is strong, like the individual that you see on the left, typical big dad belly, big legs. He was a police officer, so you oftentimes he wasn't a donut-eating police officer per se. He was a larger man, but strong. because you always have to retest physically every few years for the police department. So what we were envisioning as my father as being strong, in reality, what they were seeing was a man that looked like the picture on the right. And that part of it was very unforgivable to me. When we came into the room and I showed them this picture of this goofy picture of my dad, they were just aghast. They didn't know what to say. They didn't know what his admit rate was. And the time that I figured out that he had actually lost so much weight was only because the video call was further back on his bed, and they happened to have the bed sheets down. And so when they had the bed sheets down, it was very apparent that he had no stomach. All of the other video calls were from about the neck up, and his face looked the same way that it did in the photo on the left. But once we got this further back look, unfortunately, the nurse, who it was like her first day taking care of him, and so she was like, well, I don't know what's going on. I don't know about his weight. This is my first time. But that was the first time where I could really see, like, oh my goodness, what happened to him? Where is his stomach? And he's probably not moving his arms and his legs because he's got no more muscle, guys. This isn't who he was before he went into the hospital. And that piece is really unforgivable in some aspects for me, because if I were to put myself in the situation of being a provider and seeing that the family has a disconnect of not understanding that the patient is no longer strong, no longer the person that they were before, and now is this skinny, frail man, then I, as a provider, I feel like I would advocate for that patient and say, you know what, it seems like you have a little bit of a disconnect in the status and true state of which he's in. Let's walk you through what he looks like and then have further discussions about what his medical prognosis, along with now what his body shows us, will result in. So of course I walked away thinking, how could this happen? I was very happy to be a provider in pediatrics. I secured that situation by becoming a pediatric nurse practitioner. I don't enjoy working and treating adults. However, it was also this great shock because the adult world is so very different than peds. And in our facility, you could walk into a patient's room who's been here long term, and you know who they are. They may be a patient outside of the hospital that is a star football player, muscles, handsome, all the, goo-goo things that girls may like dote over them. But in the bed, you may see a frail, bald individual who's been here for a long time managing their cancer. So I guess in my mind, I thought that maybe this would be the same experience that we have in adult worlds, at least that there was this advocacy and wanting to know who the patient is, especially when they're there for so long. The communication lack of plan was very evident by the time that we were done, and a frustrating piece. But the lack of resources is really what stuck with me so much. The fact that we could call and not have the ability to talk with my father, when he was intubated, because they only had 2 iPads for the whole ICU unit. This was a 60-bed ICU unit. And the fact that they only had 2 was very confusing for me in this day and age in technology, and how readily each of my patients come in with a tablet pretty much every day. That was really sad to see. I walked away thinking that there must be a better way. So highlighted here is a snippet of the array of articles focusing on improving communication and formalizing concepts around family-centered care. Our amazing librarian, Kathy Zableski, quickly provided over 10 pages of articles with these similar themes: system factors influencing the use of family-centered rounds, key considerations for effective serious illness communication over video or telephone during the coronavirus disease, parent perspectives on participation in family-centered rounds, integration of mobile devices, and so on and so forth. It was evident that communication has always been a challenge pre- and post-COVID, and exciting to see that there were many articles that came out because of the pandemic, but also very frustrating thinking about our patient experience. The core theme in the literature focused on family-centered care, which encompasses 4 essential pillars: respect and dignity for all, sharing useful and unbiased information in affirming ways, encouraging patients and families to participate in care planning and decision-making, and collaborating with patients and families in the development of policies, practices, and programs. The research shows that utilizing a family-centered care approach to patient care delivery can alleviate stress and anxiety, increase family satisfaction, improve communication, improve health outcomes, and decrease length of stay. STC relies on an interdisciplinary approach, family-centered rounds, frequent family meetings, ensuring an adequate family support environment, clear information to the family, inviting the family to participate, and resources to support communication. One article was interesting in that families felt that that invitation had to be provided in order to feel like they were a part of the care team. That brings us to our next polling question. Do you feel confident in your ability to provide family-centered care in your practice setting? We will give you about 10 more seconds. Thinking about these 4 pillars of family-centered care and your communication strategies you practice with your patient, I'll now invite Dr. Amanda Mihalik to discuss strategies and evidence-based methods that are applicable to our practice setting. Let's see the results of the polling. And most of you feel great about your ability to provide family-centered care. Let's hear a little bit more from Dr. Mihalik.
Thank you so much, Sam. Thank you for being willing to share your family story and highlight for us what so many of us actually already know and understand, how difficult it is to have appropriate patient-centered care. Like most of you on the polling questions, I like to believe that we do actually a really excellent job of doing this here at PCH. But if it's okay, I'd like to take a little time to explore that further. What are the things we can do as individuals, particularly for our learners and those of us who are at the bedside frequently, to determine, let's make this better. How can we improve? We'll try and highlight some of the things we do well here already at PCH and continue on forward. So it's helpful if we go to what works in ordinary times. So we know, as Sam mentioned, a family-centered approach is really imperative. We know that it's helpful in all environments across the hospital-wide system, that it improves quality and safety for patients. It helps with the disease management of chronic complex care patients. It improves patient satisfaction and reduces hospital stays. And it also lowers medical errors. Which is really important, particularly when we're thinking about these prolonged periods of time where patients are in the hospital for over 2 weeks or even 2 months. It's also important to think about utilizing trauma-informed care methods so that we're thinking about how we deliver important and perhaps serious or difficult news, and that we're not adding difficulty to the families when they're hearing that. Of course, empathetic communication is something we'll focus on a lot this morning. And joint decision-making focused on patient goals of care is at the heart of family-centered approach, and I'd like to believe also what we do here at PCH. So family-centered care, as Sam noted, in the time of COVID is particularly challenging. We know that we need to optimize bedside communication when possible, but that's not always possible, especially when we think about the limitations of COVID. So therefore, we have to utilize telehealth and bedside cameras. There's been some nice literature published by our friends in neonatology that highlight that the use of bedside cameras, those that we have here in our NICUs, in our CVICUs, and also present in our PICUs here at PCH, help to reduce parental anxiety and distress so that at 2 a.m. when they wake up worried about their infant, they can actually look at the camera, pick up the phone if they need to, and have a thoughtful conversation about what they're seeing. It's an incredible tool, and it's something that I'm thankful we have here. We also know in the literature in the last year that there's some good information about telehealth and Zoom meetings, that they also help to build rapport and trust, just what Sam's family unfortunately was lacking with their care team. When it comes to the nitty-gritty, however, when we've looked at head-to-head studies about big topics of care, like changes in trajectory of care or end-of-life comfort care, nothing surpasses the idea of face-to-face communication. So this is a time period, if we're worried that there's a significant change about to take place, or the trajectory of care is about to change, we need to think about allowing family to be at bedside and making exceptions. Of course, the barriers that we can all immediately think of to patient-centered communication in the time of COVID, or any time really, include the PPE that we have to wear and how that creates a physical barrier, the visitor limitations, which we know in a national-wide study that looked at all pediatric hospitals, that PCH actually was within the majority. About 40% of the largest pediatric hospitals only allowed 2 visitors, 1 at a time. And we know that significantly impacts family coping, because now your significant other or your other support person is no longer able to be at the bedside with you, both receiving information and helping to process that. Medical technology, as was in the case Sam's family highlighted, not only was their dad not able to communicate because he was having difficulty breathing on BiPAP, was then subsequently intubated and sedated, but there was a lack of the medical technology to help with communication. So there's only 2 iPads on each pod here, so optimizing that would be helpful. And then crisis standards of care is something unique to COVID that we'll talk a bit more about. So despite these barriers, I still have hope and faith that we can provide empathetic communication. So a nice mnemonic that I'm hopeful our learners can utilize is I care. The idea that we can introduce and state our role and our reason for our visitation every time we meet a patient or family. We can collaborate with the patient and family. We can acknowledge the emotion as well as the situation that they're in. We can use reflective listening to really hear what they're saying. And then expectation setting is huge. We need to make sure that we're not just giving them the information of X, Y, and Z and what are the labs, but what are we expecting today? What are the next steps in care? What will we be hopeful for in the next week to see positive change? There have been some nice tools created, as Sam highlighted. There's a couple more I'd like to add for suggesting frameworks for daily communication. This group out of Ann Arbor, Michigan, that worked at the VA hospital there helped to create these strategies for daily communication. And I'd like to spend a little time going through it because I think it's worthwhile. So they talk about communication with patients, that we respond to emotion with empathetic verbal statements, that we make introductions, as we talked about, and that we utilize face and fact sheets. So while we have our badges, we know that when wearing PPE, the individual can't see our face. So having a picture, big, blown up, of who we are and some important key facts about who we are and what our goals are is really helpful, not only for the family, but for the patient. Inquiring about the patient preferences are also key. You know, here, as Sam pointed out, there's a robust utilization of advocating, particularly from the Child Life team, about who is the patient. Personalizing the room to make them feel confident and comfortable, and making sure that if it's necessary, there's also a sign-up that says, hey, my name is Sam. These are the things that are important to me. You know, when we were talking before giving this presentation, Sam shared that her dad really liked to be clean-shaven. And in those first 1 to 5 days of his hospital stay, he actually asked his brother to bring his razor. Unfortunately, that was lost in communication with the team, and so he wasn't clean-shaven when they then went to see him, and that felt like, you know, unfortunately, his dignity wasn't being reserved or preserved. So those are simple things that we can do to try and optimize care and preserve dignity for our patients in both aspects, pediatric and the adult world. Articulation, enunciation, and increased volume can be helpful when we're wearing a mask, of course. Communication with the families and caregivers is key. So identifying one family point of contact to then disseminate information is huge. I'd like to go one step further and ask that that not be the bedside parent, that we help the bedside parent identify someone in their community to be that individual. We know that it's enough to have to receive the information, but it's a whole nother level of trauma to be the point person while you're just trying to survive at the bedside. So helping that individual identify someone to help disseminate information in a safe way is key. Consider video platforms for family meetings. I can think of in the last year multiple family meetings where we've utilized Zoom, and it's been wonderful. We've had family members from across the country Zooming in to help families who are at bedside navigate these difficult conversations and make significant decisions around goals of care for their loved ones and their children. Engaging the family members and caregivers to develop a patient-centered discharge plan is key. But if we're not moving towards discharge, I want us to think about what are the next big steps? Where are the forks in the road that we can perceive that we need to be thoughtful about and we should be anticipating? If care goes this way, that's wonderful. If care doesn't go as anticipated or hoped, how do we have those thoughtful conversations? We want to prepare our families in advance to be thinking about those difficult conversations and what their goals would be. So in Sam's family situation, if I see that he is dwindling, and now I'm worried he is ICU muscle wasting and is unable to achieve the goals that we would hope, let's have a thoughtful conversation about that. In 1 week's time, if we're not where we want to be, we need to have a thoughtful conversation about that. It's also important, of course, to assess the patient and the caregiver's healthcare literacy, right? What level of understanding do they have? Sam's family was quite medically savvy, but there probably were other family members like his wife, Sam's mother-in-law or stepmother, who didn't know much about medicine and therefore weren't able to really grasp the significance of what was going on. Oftentimes, those of you who've worked with my partners in palliative medicine will hear us ask the question, how do you like to receive information? Do you prefer written word? Do you like to see images? Are the images too difficult for you to view? It's important to ask, and we'll talk about that more. Communication within the healthcare team is also important, and there's a little bit of a fad bubble right now around team huddles, and of course I'm working on that as well here at PCH. But the idea of having a separate time to work as a team that's not morning rounds is really imperative. During those team huddles, you can invite individuals like our subspecialists or perhaps even the PCP who's had this 40-year-long relationship with the patient to give us insights into who they were in the world, what was important to them. Even if we're meeting them in crisis times and we don't have the ability to have a thoughtful conversation about their goals of care, the hope would be that their primary care physician has. And that's where those two worlds can come together and work for the benefit of the individual in the bed. It's also important to consider automatic consultation for palliative medicine for appropriate patients. And I'd like to just note that that doesn't mean someone who's at end of life, that anybody who is exquisitely fragile, who's medically complex, or who's had a life-changing event, such as a prolonged hospital stay, deserves a palliative medicine consult, or at least should be considered as such. And the hope would be that we can shift away from this idea or the stigma or misunderstanding of palliative medicine as only end-of-life care. Because my hope, of course, is that it truly is not. So that's a nice framework for thinking about daily communication and big picture planning, but what about when it comes to delivering difficult or serious news? And I want to be super thoughtful about this. So there's a nice group called Vital Talks, which has incredible resources for all learners and all providers at every different level about how to optimize your communication and be thoughtful about how we deliver difficult or serious news. And they have three basic pillars to communication. The first is dealing with emotion is more important than giving lots of information. Of course, we know this. Information is best delivered in small packets and starting with a headline. So we know oftentimes we give too many statistics. We talk about the data, the labs, but we're missing out on the important big picture. And for the family, the creatinine level may be important because that's what we've been highlighting, but the big picture is the kidney dysfunction and how that will impact the life moving forward. Also key, of course, is that the patient values should be at the center and the heart of the medical treatment plan, even if that treatment plan is arcing towards the recommendations of the medical team. So if they feel that their values are what are at the heart of that, then it's more easy to accept what the medical team is offering and sharing. The impact of crisis standards, what I had mentioned briefly before on this practice of communicating difficult news, is unique to the time of a pandemic. And under crisis standards, the ethical foundation shifts from what the individual values are to population-based resource allocation. So this is the idea that maximizing the most good for the largest number of people. So this, of course, eliminates some choices for patients and families, and the team must share what is actually possible. They need to refrain from offering treatments or interventions that aren't available to the patient. So if ECMO is not going to be a useful tool, we shouldn't even be mentioning ECMO because we might actually add to the trauma or worry or anxiety to the family that, gosh, maybe there was this other thing that the team should have done, and now I don't trust them because they're not willing to use it for my loved one. We want to be thoughtful about that. We want to share how crisis standards impact the family and what they truly mean. So that might be something simple as there's only allowed to be one visitor at a time, or if we're going to have a family meeting, 2 individuals can be present, but we need to use Zoom to include the others. Responding to emotion has been key here, so I want to take some time and talk about that. We know that nonverbal communication is the fundamental way that we convey empathy and we build trust with our patients and families. The reaction to emotion matters because we know that it lowers anxiety levels and it allows families and clinicians richer and more authentic insights into what is most important. Attending to emotion enhances a clinician's ability to manage difficult conversations while allowing them to convey compassion and build trust. So all too often, even before COVID times, people will become tearful or emotional, and our go-to is to talk about statistics. Well, maybe there's an 80% chance, or maybe there's a 15% chance, but those things actually nullify our ability to be present, to sit in silence and recognize that this is an emotional time, and takes away from our humanity. So how do we convey empathy when we're wearing PPE, right? If that's the way we communicate nonverbally, how do we do it? Well, we can do a couple of things. We can attend mindfully. One of the things that I like to do is create ritual to focus my attention. So we all have to gel in and gel out, right? So when I gel into a room, I leave everything that I just came with behind me. I try and open my mind to the clinical situation in front of me and meet the family where they are. I might have an agenda about what I'm hoping to discuss, but my hope is that I can be opened and listen to what the family has to say and impart those headlines that I want to. When I leave the room, I gel out. I leave the emotion or whatever the trauma is behind me as a coping mechanism, and I bring forward with me only what I need to bring to the medical team to help improve the care and advocate for the patient moving forward. It's helpful to consider the ways that we typically communicate in gesture and tone when we're not constrained by PPE and distance, right? So I'm a big talker with my hands, or I might use my eyebrows. So thinking about when I'm communicating difficult news, how would I normally posture? What would my hand gestures be? And then trying to utilize that to highlight my language and align my nonverbal signals with my spoken language when I'm wearing PPE. Behaving calmly is important. So those with functional and cognitive limitations will become more comfortable if they feel respected and they don't feel rushed or pressured. Approaching an individual from the front is always important. It allows them time to process you and to recognize you not as a threat, and also try and understand what you're going to ask of them. Dropping down to eye level. Remember, we all know this from med school or from training. It's important to be at eye level. And the reason that that's so important is it brings the power dynamic to equal. And I would even argue that if you are dealing with someone who's frustrated or anxious, perhaps drop below eye level. Give them a bit more control in that conversation. It's important to project a calm and positive attitude and avoid body language that shows that you're frustrated, angered, or impatient. So a nervous ticking of clicking the pen might be that you're uncomfortable with this emotional conversation, but unfortunately that might be a nonverbal cue to the family that you're impatient and you don't have time for them, or that you're actually annoyed or angered by what they're doing. So we need to be thoughtful. Try not to interrupt. Give them time to speak. We know there's all those nice studies out there that we wait, 9 seconds before we interrupt patients. So try and really listen. There's been some recent care conferences with, quote, difficult or challenging mothers. And if we give them 5 minutes to just come full circle and express their desires and their worries, they actually end up meeting us where we want to be. And we don't have to have a contentious conversation. So give them time. Allow them to speak their piece. It helps them to feel heard. Silence pagers, and please actually put your phone out of sight, because that is really helpful. And having it in line of vision actually is a distraction and makes you think about what's next. Communicating clearly is huge, so avoid loud spaces. Most of you know when we have care conferences, we try and go to a quiet space, not in the patient room. Ensure that you're utilizing their primary language. So there's been some unfortunate research out there recently from Rush, where when they looked at COVID units and hospital stays and how many family meetings or care conferences were discussed, those who were Spanish speaking or of Latino origin had fewer family discussions and often waited twice as long, unlike their white and black counterparts, to have family meetings or discussions about important things like tracheostomy tubes or comfort care. And the only kind of key that they could see was that it was the language barrier. So that's really unfortunate and just emphasizes the healthcare discrepancies that exist already. Ensure that they have their hearing aids and their communication devices, and I would go a step further in pediatrics that if they're old enough to be engaged in their care, that they be invited to participate in the conversation as well if they can. Underline your words with gestures, like we said. Over-articulate. By over-articulating, it actually slows down our speech and allows us to pick our words more thoughtfully and carefully, so we can use fewer of them. Using a lower pitch to facilitate understanding and slightly increasing the volume without yelling is helpful. And sometimes it might be helpful to even mimic the gestures or tone of your patient, but I would be thoughtful about this. We don't want them to think you're mocking them or that we're making fun of them in any way. Verbally responding to emotion is important, and then considering written or pictures as aids may be helpful. The words we choose, of course, are really important. So it's important to ask permission. I'm hoping we can talk about what's important to you so that we can provide you with the best possible care. Is that okay? Or perhaps I have some really important or difficult news I need to talk with you about. Do you have time now? And is there anyone else you would like to be here with us while we talk about this difficult topic? It's important to share with compassion and attend to emotion. I like to use the wish, worry, wonder tool that those residents who've rotated with us have heard about. I hear that your goal is X. I worry that your child is too sick to achieve that goal. I recognize that this is not what we had hoped for, and it's very difficult news. And then pause. It's important that we maintain open-ended communication and questions about what's important to the patient and family. So, given this new change, I wonder what's most important to you. What are you most worried about? How can we move forward together? And always, it's important to reaffirm commitment to care. So we will do everything in our power to focus on X and help you and your family. Those of you who've worked with me in care conferences know that I often will say it's important that you know that as medical providers, our job is to first and foremost keep you safe, to ensure that we're communicating honestly and openly, and that your care is in line with your goals. So there's many tools, and for the sake of time, I won't go through all of them, but it's important that we're engaging the patient and family, that we're utilizing both synchronous and asynchronous communication. So that means communication with both the patient and family, as well as with the family alone and the patient alone. That we're engaging the family and the patient in the environment. So asking the family, what's important about your patient's environment? And asking the patient, what's important about your environment? It's also important, like Sam was saying, to disclose what does the room look like? What does the patient look like? What is it that they're experiencing on a daily basis? And how can we optimize that to improve their quality of life while they're going through this? Communication between the clinical teams and families is imperative. And we talked about including family on rounds, trying to utilize, phone calls at key clinical changes, and that might be a room change or when the patient is coding. So thinking about those big important times. And then asking family to share who is this individual? As Sam did at the end with her dad, showing pictures to the medical team. That's hugely important. So while there's lots of new tools out there, it's important to think about what else? What else can we be doing? And particularly here at PCH, how can we be optimizing our communication here and in the community? And what might have improved the story for Sam's family? So I'm going to turn it back over to Sam.
So I wanted to share what we have here at Phoenix Children's. Here's a fun photo of the Division of Patient and Family Centered Care. I've had the pleasure of meeting with Andrea Akinova, our new director over this department, and she provided the following to me to articulate to you today. The vision for PFCC is that we create organizational alignment and commitment to partnering with patients and families in a manner that ensures PCH is collaborative, coordinated, and accessible place to receive care across the continuum, enabling patients and families to make informed decisions while receiving exceptional quality care. I want to welcome Andrea as we're looking forward to working with the team and what they will accomplish. I'd also be remiss if I didn't give a shout out to Teresa Boger, who's helped set my perspective on the concepts of patient and family-centered care and the great work she does with our patient advisory councils and previously as the director for this department. So at this point, I am a self-proclaimed IT nerd. I get really excited about the things that IT is developing for our hospital, and our IT leadership shared this with me. These are the different patient engagement initiatives that are slated for 2021. I cannot speak to what we're doing, who's rolling them out necessarily, and I do know that the patient to-dos I'm very excited about in ambulatory. But this is just a snippet of the work that our IT department really values with patient engagement, which of course encompasses improvements from a family-centered care perspective. So I'm the type of person that when I see gaps in care or when I'm upset about something that I feel can be better, then I feel like I want to act on that. So my experience with my father has prompted me to start a nonprofit organization to improve family-centered care in the community. And what first came to mind after our experience is the lack of the iPads in the ICU. So I had many different people who donated to purchase iPads for the hospital and the ICU unit that my dad stayed at. And I was also able to collect donated iPads and donate them to the chapters at the UMCT. Once I started down the road of collecting resources, it was also very challenging because even certain hospital organizations here in our state, when I contacted the foundation, they actually denied iPad donations. They said they didn't have time for the iPad donations. And so after that venture, I went into the realm of developing education that perhaps we can provide at the provider level, which brings us here today, and also for our patients. So from a grassroots level, being able to empower our patients to understand how to better have a relationship with us as providers, and also how to advocate for their needs and their values. And so Speaking Life is an organization that will be nonprofit, offering exactly what I'm not completely sure, but in my spare time, I'm developing different tools and resources to help our Arizona community have a better relationship with their providers, embodying the concepts of family-centered care. I want to thank you for your time, and most importantly for your interest. We know that you can choose which grand rounds you guys attend, and I want to thank you so much for thinking that this topic was important to you. Here's the contact information for both Dr. Mihalik and I. I want to give a special thank you to Amanda for her true blind trust in partnering with me. I heard that she was a great from Tressia, and I shot her off this email. She didn't even know me, and I just said, hey, I really want to do a grand rounds, and I heard that you would be excellent in doing a presentation with me. So thank you so much to her. I've learned so much in enhancing my ability to have difficult conversations. Arguably, I feel like I have more difficult conversations in my IT role than I do in dermatology. No offense to anybody. But thank you so much for joining us today, and we'll open it to questions.
Dr. Mihalik, Dr. Castleman, thanks so much for that great presentation and for your stories, and also just the great reminders on bedside manner. I learned a lot, and definitely some great tips. So I have some questions for you. I want to start with a great question from Josh Cook in the ICU. He asked, when my father died this past winter, one of the best things the inpatient hospice team did was ask us about shaving him, and doing that when he was transferred from the ICU. It was incredibly powerful and humanizing. I never would have thought that as a provider. What are some pediatric equivalents that are really powerful to families that we may not think of as healthcare providers?
Yeah, it's a good question. I think it's probably individual to the patient, but being able to bathe or wash the hair or to or to braid the hair of a child or to paint their nails, those kinds of tender things that allow them to be human and back to themselves are really powerful. So I think that's key. The other thing I would say is being able to dress them in the clothes that they're most comfortable in. So if we can get them into the things that they identified or that they loved themselves, that's really powerful.
You talked about how to kind of control your emotions and deal with emotional situations. And I guess I just wanted to interact a little bit more on that. When it is a tough topic, whether it's end of life, whether it's a family that's frustrated and upset, I think it is difficult to control your emotions as the provider. I guess can you talk a little bit more about some tips from the provider standpoint about trying to maintain that calm presence and not give off cues of being nervous?
Frustrated. Yeah. Absolutely. So I think the first thing is naming the emotion in the room is helpful. A lot of times we're all thinking, man, this mom is pissed at me, right? Or she's so angry. But I think it's helpful to actually, excuse my language, but I think it's helpful to actually say, I really hear that you're frustrated, or I can hear your disappointment in this. And I too am disappointed, or I too am frustrated by this. So in that way, we're mirroring them, and they recognize that this is a frustrating situation. So again, attending to emotion is really key. So the more we can actually name it, it kind of diffuses the situation. So, the people who I think of that communicate best with patients when there's difficult emotions flying around the room, it's those who are willing to name it and then sit in that. And it's okay to say, I hear your frustration. I know that this is a difficult time. I want to see how we can move forward in a positive way. Saying sorry is not always very helpful, but I would say recognizing the emotion and trying to sit in it is fine. Being silent is also okay. But I would first recognize the emotion before I sat in silence, because we want to make sure that the family doesn't perceive necessarily that you're ignoring them or that you're so shocked that you don't know how to respond to them, but rather that you're really seeing them for who they are. So recognizing, using the words, I recognize that this is not what we'd hoped for. I hear the frustration and the sadness in your voice, and my hope is that we can move forward in a more positive way. These are the things that I think will be most helpful. Tell me what you think would be most helpful. Engaging them and what would actually optimize it. And they might be so upset in the moment they say, I have no idea. I don't know what to do. And that's where you can pause again and say, well, I think these 3 things would be really powerful and helpful. If on rounds, you could join us in the morning so you hear the care plan. If in the afternoon, when I do my second rounds as a resident at the bedside, I call you and I try and give you an update. And once a week, we think about having a care conference like this to optimize our communication and make sure you really feel heard, because I understand that you're not able to be at the bedside all the time. So giving them a game plan is also helpful.
That's great advice. How about in delivering bad news? Not so much a frustrated family, but a family that you know is going to be crushed by what you're about to say. Again, kind of from a provider standpoint, being in control of your emotions.
Yeah. Well, I think it's important to show authentic emotion, right? So if you've had a long-standing relationship, like a lot of our BMT and oncology providers with these families, they know who you are and you know them well. So honoring and respecting that, I think it's helpful to show authentic emotion, to be disappointed, to be truly authentically sad about the situation. But also you need to be the guide in that conversation. So again, using headlines and asking permission are key. So I need to have a serious conversation with you about some really difficult news that I'm not happy to have to share with you, or that is upsetting to have to share with you, but is really important. When do you and mom have time to sit down and have this conversation? Opening it up like that, the family is going to know this is something serious and that it's important, and that you're also sad that you have to share this information. And then finding time and space to have that, putting away the phones, all of those things. And then saying, giving them that warning shot. I need to share with you some really disappointing and upsetting news. And that is that there are no more curative therapies, XYZ, that are going to be of benefit, and it's time to start focusing on comfort, because I worry that anything else I do might actually contribute to harm. Now let it sit in, let it settle, because then they're going to ask a million questions, right? But having a simple, very clear statement is really important. Going through the numbers in the labs, people are going to get lost. So being authentic is okay, and sharing your own frustration and disappointment is helpful. I think it recognizes how powerful the conversation is. One little thing I would say is, well, it's important to have tissues for families when they're upset. I want to make sure that we're never pushing them into somebody's lap. So unfortunately, it is a nonverbal signal when we hand someone a tissue that maybe we're telling them your emotion is not welcomed here, or we don't want to see your tears, clean yourself up. So I know that's never anyone's intention, but it's okay to simply address the tissue box in front of them. And if they want to take it, they absolutely will. But handing it to them while they're in the midst of emotion actually shuts them down. So it's important to give them time to experience what they need and then take that tissue if they need it. So just a tip for people in care conferences or when delivering difficult news.
Dr. Castleman, Dr. Mahalik, thank you so much for the timely and fascinating presentation today. Really enjoyed it.
Thank you. Thanks, everybody.
Have a great day,
Have a
everybody.
great day.